Hi, everybody, and welcome to part 3 of our shock discussions. This is the organ's response to the shock cascade. So, as a little reminder here, the body's response is related to the sympathetic nervous system. So, the adrenaline with the increasing of the cardiac output and elevating of the tone. Cortisol, which gives us energy, and that includes the glucocorticoids, so giving us glucose. C-reactive protein, which inactivated form of CRP leads to clotting. Anaerobic metabolism, which leads to lactic acidosis. And then the kidneys and their functions to help not only with tone with angiotensin, but volume with aldosterone and antidiuretic hormone. Remember the role of the mean arterial pressure and the need for perfusion to our organ systems. Okay, so we'll launch right into this, the respiratory system. When you think about the organ systems in general, I think that knowing what you know about it for what it should do when it's healthy can let you know what gets messed up when it starts to fail. So the respiratory system is the first organ system to decompensate. So you might notice the increase in the respiratory rate. The lungs get tired. Remember, in hypermetabolism, it requires more oxygen and glucose to do the same work. So the person will get tired pretty quickly, and it can lead to hypoventilation. And at that point, we are no longer in respiratory alkalosis, but perhaps respiratory acidosis as we start to retain the CO2, and then we devolve further into metabolic acidosis as lactic acid continues to be increased by a body that is in anaerobic metabolism. When our alveoli become hyperperfused, it can lead to atelectasis, which in turn can lead to a bacterial source of contamination. The leaking can occur due to the inflammation, so capillary and alveolar leaking, which we may see manifested as pulmonary edema and crackles, and also we have the problem of shunting in the lungs. This can lead to an acute lung injury, or even worse, acute respiratory distress syndrome, which we talk about under respiratory, but basically it's an end-stage respiratory problem. So that's when, if you were to check the blood gas, the PaO2 is decreased, so you give more oxygen. And despite giving the oxygen, the PaO2 continues to decrease or not improve. So that is the effect of shock on the lungs. The cardiovascular system can also be affected by shock due to the ischemia. So myocardial ischemia can lead to dysrhythmias or irregular heartbeats, which can lead to disruption in the cardiac output as well. The person often experiences tachycardia as we try to compensate, and also the heart is working very hard to maintain that cardiac output. Chest pain can result, and remember, chest pain can have many sources. But for here, when we have decreased perfusion, we can end up with a myocardial infarction, of which troponin is the marker, or we can end up with heart failure, of which the B-type natriuretic peptide or brain natriuretic peptide, BNP, is the marker for CHF. The cardiovascular system can add a layer of difficulty onto shock. For example, somebody might start with hemorrhagic shock, so a problem with the volume, and suffer a myocardial infarction, and then end up with not only hypovolemic but also cardiogenic shock as well. And just a little note here that acidosis can also cause dysrhythmias as well. So the BNP, as a measure of heart failure, it increases when the ventricle is overdistended and can give us a pretty objective measurement of the level of heart failure. Neurologically, there are changes that occur due to decreased cerebral perfusion. So various stages of altered mental status, which can start with agitation and confusion, can proceed to lethargy, into obtunded or somnolent. So obtunded is a worse than lethargy, and then eventually into a coma. Brain swelling, ischemia, and increased pressure, coma, and death are all possible sequelae from shock. The kidneys can also be damaged during shock. And this is if we get the MAP of under 65 that's sustained. So for longer than a few minutes for sure, but definitely sustained MAP under 65 can cause decreased perfusion to the glomeruli. And the labs that we look for are the BUN and creatinine. And honestly, the BUN is more to do with fluid status, and the creatinine would be more specific to renal function. And anytime we have a renal impairment, that can lead to fluid and electrolyte imbalances and loss of hormonal blood pressure control. So think about that renin system and aldosterone and antidiuretic hormone. They have a role in fluid and tone. And previously, you guys all learned that urine output of 30 mLs per hour is sufficient. And at this level, I want you to now go a little bit deeper and understand that a larger person needs more urine output to have perfusion than a smaller person. So think about the 350-pound linebacker from the Buffalo Bills and his urine output compared to that of an 80-year-old female. So, for example, somebody who's 100 kilograms or 220 pounds, they would actually need 50 mLs of urine an hour. And if they were at 30, by the basic definition that we knew before, we would say that they were fine. But with this new, more specific definition, we would state that they needed to have more urine output. And the question is, where did that 30 mLs per hour come from anyways? More than likely, it had to do when the average patient was probably smaller than what we deal with. So if you did it for a person who's like around 60 kilos, then 30 mLs would be sufficient. But certainly not when they're bigger. So the best way to figure out their urine output now is no longer 30 mLs an hour. It's weight-based. The liver can also suffer damage during shock states. The liver is so vitally important to normal functioning. So we'll take a peek at that right now. Things that the liver does. I once had a doctor who taught me a joke. He says, "Why do you call it the liver?" And the answer was, because you can't liver without it. So some of the functions that the liver does, of course, the metabolization of a lot of medications and drugs are done with the liver. The lactic acid is broken down in the liver and used to make not only glucose, but bicarb. We can't regenerate the sugar supply. We have increased risk of infection because the liver does filter bacteria, which is why people who already have one shock state are at risk of sepsis. And how do we monitor this, right? We look at the liver function studies, including the bilirubin. We look at signs and symptoms of liver failure in the patient, including jaundice. They might have hepatic encephalopathy, so that would mean that they would have an altered mental status as well. So just remember, now more than ever, the body needs the liver to break down lactic acid. This can be a terrible thing for patients. The next thing to look at is the integumentary system. So the skin becomes cool and clammy due to vasoconstriction. And understand, though, in septic shock, the skin may not get cool and clammy, especially in warm shock that we generally have an area of hypermetabolism before we go into cold shock, but that's a different lecture. But just to understand that with septic shock and any vasodilation shocks, that they may end up with dry and flush skin. But what is it when we talk about modeling? It's a lacy network of like a patchwork of red or purple. And basically, it's the body will sacrifice the limbs to save the core. Some medications can cause this. So some medications we give to cause vasoconstriction to increase the blood pressure. But at the end of the day, this is the capillary bed shutting down. So the modeling on the upper extremities does indicate impending death, a lot more than we would say the changes in the lower extremities. Gotta move that over. All right, so the GI system here. Let's see if I can, well, we'll just center it as much as we can, but the GI system. So a couple of different things can happen with the GI system during shock. One, of course, is stress ulcers and GI bleeding. And you should be asking yourself right now, how do I know if somebody has a GI bleed? What are some of the things that you might think of that could tell you a person has a GI bleed? Might it be a positive stool for occult blood? Might it be actually visualization of bleeding with the stool? Could they have coffee ground emesis? All are examples of somebody who has a GI bleed. Ischemic intestines can result in a GI bleed down below, and it could also lead to sloughing of the intestines, so you might see mucosa in the stool. Bacterial translocation. So remember, when we have capillary permeability, this allows some of the normal bacterial flora to move out of the bowels and into the blood, so then this can cause bacteremia. So we don't want any bacteria that would normally be sitting in the bowels now circulating in the blood. Then, of course, the risk of a secondary septic shock. So the meds that are used, again, are proton pump inhibitors, as well as H2 blockers, as well as early enteric feeding, right? Remember, we talked about the role of increasing peristalsis to keep the gut perfused and working. And then the hematologic system as well. It's a good spot to talk about DIC as well. So remember the cytokine storm and inactivation of protein C, which leads to clots to be formed and in such a rate that it uses up our clotting factors and our platelets. And as a result, the person starts to bleed. And also in our hematological section, we want to talk about bands. Remember, bands are immature neutrophils. So an increase in bands indicates that all mature neutrophils have been released from the bone marrow, usually during severe inflammation or infection, or that the marrow is now releasing immature cells. So if you go back to where we talked about that SIRS criteria, this is why 10% of bands is in the SIRS criteria. Remember, what is normal? Normal is 3% bands. So imagine you had a normal bands and then you notice that the bands were increasing. That is the sign that things are probably getting worse or going to be worse the next day. Okay, and to wrap up this section, we'll talk about the goals of shock treatment and some of the indices that we would like to see. So, of course, to identify and correct the underlying cause is of paramount importance. We need to increase oxygen delivery, which is why we give them high flow oxygen, and decrease the demand for the oxygen. Try to get them out of that hypermetabolic state by correcting the underlying issues, but we may also use sedatives and other medications that decrease oxygen demand. We want to have the person have an appropriate mental status and preventing delirium. Delirium is absolutely deadly, and ICU-related delirium can be a big problem. And believe it or not, the best way to treat ICU delirium is to get them out of the ICU. We do have to walk a fine line between mobilization and sedation. So we want to make sure that we're only giving people sedation who need it. And otherwise, we want to limit it so that the person can start to move around and prevent some of the complications. Lactic acid levels do need to be normalized. We want to maintain or obtain a urine output of greater than 5 mLs per kilogram per hour. A little caveat to that is that some of the medications we give, though, they work by decreasing urine output. So you want to take everything in context with what you're looking at. The central venous pressure, which we said is a measurement of fluid status. So 2 to 6 is going to be what is normal. So under 2, we would say that the person has too little fluid on board and would need some fluid. And over 6, we would state that they have too much fluid on board, and therefore giving them fluids would not be appropriate. In fact, may cause circulatory overload. The pulmonary artery wedge pressure, which is a measurement of the left ventricle and assessing left ventricular function. Again, this is done by invasive cardiac monitoring, so the Swan-Ganz, but our normal there is 6 to 15. Again, that measures how the left ventricle works. It doesn't have anything to do with that necessarily specifically with the fluid status, though it can be impacted by it. And then our MAP, we want to keep our MAP 65 to 90. And we want to keep our venous oxygen saturation at 70%. We do have the ability to monitor these things rather closely. So we would use continuous monitoring. Of all of these, I want to say the ones that we concern ourselves the most in level 3 would be our urine output and our central venous pressures. In our MAP, with the understanding of what the others are and what they mean. Okay, guys, so that is going to finish part 3 of shock. Thank you.